It has been over 20 years since the beginning of the patient safety movement led by the Institute of Medicine. However, prior to COVID-19, medical errors were the third leading cause of death in the United States. In spite of an intense focus on creating safer healthcare systems, institutional culture remains the most significant barrier to safe care. Organizations have struggled to build and maintain a safety culture, which is shared safety beliefs, values, and norms that influence safety actions and behaviors. Staff nurses consistently over time have the least favorable perception of safety culture, whereas leaders consistently have the most favorable perception of safety culture. The purpose of this qualitative inductive descriptive study was to understand the discrepancy in safety culture perceptions by exploring and describing medical surgical staff nurse and nurse leaders' safety culture experiences, and then comparing and contrasting the experiences between the participant groups. The purposive sample that saturated at 16 staff nurses and 10 nurse leaders resulted in 6 themes describing safety culture experiences within each participant group. This was supported by descriptors, which were rich descriptions of the meaning of those experiences. Because both participant groups used similar language, 6 shared language categories were developed. Staff nurses and nurse leaders described relationships with patients, nursing interventions, relationships with colleagues, resources, the organization prioritizes patient safety, and learning. And this resulted in making sure patients were safe. Staff nurses made sure patients were safe by being able to provide safe care, whereas nurse leaders made sure patients were safe by making sure everyone was doing their best to provide safe care. And although staff nurses and nurse leaders used similar language, the meaning to describe that language was similar in only 34.3% of the cases. 8.6% of the time, the descriptors were unique, as they were only described by one group of participants, and 57.1% of the descriptors were either different or in discord. So although the language was the same, the meaning of those experiences within the language was different. Now imagine you're a nurse stepping onto your unit at the start of your shift. Before you even clock in, you hear alarms beeping. You see nurses moving about busily. No one is sitting in the nurse's station preparing to go home. You can just feel it's going to be another challenging day. Throughout the shift, you have countless tasks to complete. Supplies and equipment needed aren't available, and it will be a struggle to get them. Your patient in room 402 isn't doing well. Your patient in 410 is a fall risk and keeps setting off their alarms. You haven't seen your other patients in hours. Thank goodness for your teammates, or you would never get through the day. Your patient in 402 continues to worsen, and you can't get the doctors to see the gravity of the situation through your eyes. You keep calling, but you get yelled at and hung up on. Before you know it, the next shift is waiting for a report. You leave after over 12 and a half hours feeling physically and emotionally exhausted, and you feel like you didn't give good care to any of your patients that day. Now imagine you're a nurse leader and it is your ethical absolute duty to ensure a safety culture, yet you describe many of the same barriers as your nurses. This leaves you feeling exhausted, like you weren't doing anything good at all. In this study, staff nurses didn't have enough time to get everything done, to know and care for patients, to build relationships, or to learn. They worked together as a team, which helped them overcome inadequate staffing and contributed to their description of the safest day. They described poor relationships with physicians that influenced behaviors leading to unsafe care, and this caused them to feel a lack of respect for their role in providing safe care. Nurse leaders acknowledged staff nurses were busy and didn't have enough time, but they acknowledged that financially responsible staffing was challenging, and that overall, the relationships between physicians and staff nurses were poor, but they had little authority to do anything about it. The safest day for a nurse leader was when they walked on their unit and there was a clear plan in place to keep patients safe. However, nurse leaders themselves didn't have enough time, support, or resources to make sure patients were safe. This also caused them to feel a lack of respect for their role in leading safe care. The study set forth to understand the similarities and differences in safety culture experiences between staff nurses and nurse leaders, but the real learning was actually in understanding the similarities in experiences. Both groups of participants experienced significant barriers in providing and leading safe care. They need their organizations to be able to help support and understand their making sure process. Organizations must set and hold everyone accountable for safety first behaviors. Relationships between all members of the healthcare team must be better understood and improved. and the physical and emotional toll staff nurses and nurse leaders experience daily must be further understood to support a fundamental paradigm shift in these roles to realize safer patient care within a safety culture. In conclusion, staff nurses and nurse leaders experience barriers daily to making sure patients are safe. Relationships are foundational to safe patient care. Organizations must understand the psychological, behavioral, and situational aspects influencing a safety culture and safer patient care. It has been presumptuous to expect a change in culture without a richer understanding of the experiences of those working within the culture.